Thank you all for joining us today for our informational webcast on navigating the 2023 Provider Appointment Availability Survey. My name is Laura Peth. I'm one of the principals of the Mazars Healthcare Consulting Practice, and I lead our compliance team. Many of those members reside in our Sacramento office and lead all of our efforts for the Provider Appointment Availability Survey, as well as other CMS and accreditation surveys. Today, I'm very excited to have Sunshine Strong and Daniel Moore join you to present their knowledge on the changes in measurement year 2023 and ahead for PAAS. Our team has been performing these types of surveys for the DMHC since 2017 and has been working in managed care within California for over 20 years. So we have a lot of knowledge, not only about the survey, but how it connects with some of the other operational areas and regulatory requirements as well. With that, I'd like to hand it over to Sunshine Strong. Sunshine?
Thank you, Laura. Welcome, everyone, and thank you for attending. As Laura mentioned, I'm a manager within our healthcare consulting practice. I've been with Mazars for almost 4 years now, and I've been working in the PAAS universe for the entire time with Mazars. Before coming here, I spent 10 years in health plans operations management and provider data management. Now, Daniel, would you like to introduce yourself?
Yes, thanks, Sunshine. My name is Daniel Moore, and I'm a senior data analyst here at Mazars. I've been with Mazars for about 15 plus years, but really my focus since 2017 has been on the Provider Appointment Availability Survey. And I just kind of the boots on the ground here from template preparation to survey outreach management, and happy to meet with you all today. Thank you.
Today, we will have a very brief overview of PAAS, go over the major changes and updates for measurement year 2023, discuss some of our thoughts on best practices for conducting PAAS, and hopefully end with plenty of questions and a robust discussion about the entire PAAS process. Our purpose today is to share our expertise and thoughts. This is not a sales call. We really want to be able to answer your questions and encourage networking between all of you. We're going to spend about 30 minutes going through this information to leave plenty of room at the end for questions. Please do hold your questions to the end. There is a QA box. You can put your questions in during the presentation, and we will get to them at the end. We are recording this session, and we'll send out links to both the recording and the slide deck to all attendees within the next couple of days. We know all of you are experienced and familiar with the origins of PAAS and the Knox-Keene Act. We don't want to go over the details, but do want to spend a little bit of time setting the scene. By March 31st of each year, health plans are required to submit to the California Department of Managed Healthcare, or DMHC, a timely access compliance report that includes information related to monitoring network access and network rates of compliance for each time elapsed standard during the previous calendar year. Over the years, PAAS has continued to evolve and change, but one thing that hasn't changed is the DMHC's continued interest in the survey, how it is executed, and the results it yields. This interest is evidenced by the enforcement actions it has applied over the years related to timely access, ranging from $1,000 all the way up to $1.5 million. We are aware that the DHCS has increased their enforcement fines and anticipate that the DMHC may follow suit. This year, a number of changes in the PAAS methodology have come out, and with that, it's a good time to talk about what's new and also revisit some tried and true best practices. After much anticipation, California's Office of Administrative Law has accepted the new regulations related to timely access, which will take effect April 1st, 2023. The most significant change in the methodology for measurement, or MY 2023, is the establishment of a rate of compliance. While the rate of compliance is something that has always been calculated and presumably reviewed by the DMHC, until now, a specific threshold has not been set. Starting this coming year, the rate of compliance is 70% across each network for both appointment types, urgent and non-urgent. The thought being that if you don't get an appointment with the first provider, by the third provider, that percentage will get you to an appointment with a compliance rate of about 98%. Additionally, the DMHC has expanded the types of specialist physicians that are included in PAAS. In prior years, cardiology, endocrinology, and gastroenterology were the only types of specialists included. Starting this year, this is expanded to also include specialties listed in blue here: dermatology, neurology, oncology, ophthalmology, otolaryngology, pulmonology, and urology. And, I'm really glad I could say otolaryngology right the first time. In terms of executing the survey, there are some other changes. While the sample sizes established in measurement year 2019 continue to be used, there is now a requirement for the sample size in a county to be achieved. If the plan does not survey sufficient providers to meet the required sample size, they must include in the quality assurance report a narrative explaining the reasons why the health plan failed and what corrective actions will be taken to ensure meeting the requirements within the next year. This might include starting the survey earlier if the plan ran out of time, or mailing flash notices prior to outreach to encourage participation from your providers. The network capture date has shifted from December 31st to January 15th, giving you 2 extra weeks. And additionally, the DMHC has provided more details about information that must be included in the PAAS quality assurance reports. Another area where we see change is telehealth. In particular, while the telehealth county has historically included providers who offer telehealth and in-person appointments, going forward, the telehealth county will only consist of providers who only offer telehealth. Providers who offer both telehealth and in-person appointments will only be surveyed in association with their physical offices. Providers are still able to respond with telehealth appointments if available. Additionally, when beginning surveys, providers are to be informed that they can respond with in-person or telehealth appointments. When giving appointment times and dates, if a provider does not specify the appointment type, surveyors should ask whether the appointment day and time is for an in-person or a telehealth appointment. And finally, for providers listed as providing both telehealth appointments and in-person appointments, the results should be recorded to the physical location of the provider. All of that said, given some of the confusion about the current language related to telehealth within the PAAS methodology, as well as the impacts of AB 457 on network reporting for telehealth, particularly third-party providers, we anticipate that the DMHC will likely provide more guidance regarding telehealth. So keep an eye on those DMHC FAQs. Now that SB 221 has been codified, there are some options for health plans. The additional follow-up appointment survey for non-physician mental health providers can be conducted separately from the rest of your PAAS survey, but it really makes the most sense to ask the additional questions regarding mental health provider follow-up appointments during the same time frame as your PAAS outreach. The DMHC already has pre-approved questions to gather the follow-up appointments, so you don't need to go through the process of getting extra questions approved. The additional follow-up appointment questions only apply to non-physician mental health providers. These include licensed professional clinical counselors, psychologists, marriage and family therapists, and social workers. As well as establishing a rate of compliance, plans will now need to develop corrective action plans for networks that do not meet the 70% threshold. After 3 months of implementation of the cap, plans will have to submit an amendment to the department to demonstrate their compliance. Also, new regulations include additional details about the quality assurance processes that plans must have to monitor their timely access and network adequacy on an ongoing basis. A CAP may address issues by looking into historic data from previous PAAS outreach and targeting those groups that have historically not met the thresholds with incentives or sanctions. Outside of PAAS specifically, there are some other notable changes. Advanced access, which applies to primary care providers, need to be verified every 3 years and can be incorporated into their credentialing and re-credentialing process. The enrollee experience survey is addressed, including a requirement to evaluate enrollees' experience with interpreter services. And lastly, the provider satisfaction survey also requires an evaluation of providers' experience with the plan's language assistance program. With that, I'd like to hand it over to Daniel, who's going to help discuss some PAAS best practices.
Thank you, Sunshine. And as she mentioned, I will be taking you through some best practices that are, in my experience, helpful to keep in mind as you go through your preparation, your outreach, and your summary. And we'll start here with project timing. Timing is very important, and making sure that you're prepared prior to kickoff is huge, that you have a good base to start with, a good foundation to start from before you jump out into the outreach. So in terms of project timing, I would start planning the process as early as you can. You're able to start survey outreach as early as June 1st, and of course goes through the end of the year, December 31st. However, once the ANR is submitted in March and April, you really could get started as soon as that's submitted. So as soon as you have your ANR into the state, you can turn around and start preparing your contact list. Even though outreach can't start for another couple months, you can be doing that preparatory work. You can be developing your contact list, preparing your outreach plan, looking at which counties you want to do a census in versus which counties you want to do a random sample in. If you're going to do a random sample, how many providers you think you'll need to outreach to in order to get to that random sample. All these things can be worked into the planning process and can all be done prior to that June 1st date. And when you are timing out your project, one thing we like to do here at Mazars is we always try to build in a little bit of wiggle room into our waves. So as you know, we have to have a gap in between our outreach timeframes. We have to schedule outreach twice during the year, reaching out once during wave 1, once during wave 2, with a gap in between. I like to build in about a week and a half into both of those waves, where just basically wiggle room, so that we can deal with things like natural disasters, like fires that have happened in the past, or labor movements, or anything that comes up in terms of issues with your outreach team, sickness in your department. The the pandemic was a huge one. So having some wiggle room in there and giving yourself some room really alleviates the stress of the process. We typically like to complete our outreach prior to Thanksgiving, just to make sure we're not running into those fall and winter holidays, which will affect your network's availability as well. So timing is crucial, getting everything together, having a plan before you get going. Of course, no battle plan survives an encounter with the enemy, but you can be as prepared as possible before you get started. And we do typically use between 4 and 6 weeks, sometimes as many as 7 weeks, to really get our plan in place before we jump off. So again, just make sure that even though you can't get started until June 1st, you're really utilizing that time well, and making sure that you're ready to go. The second item on our list here is the contact lists. The contact lists are a large part of the process and really critical to just get exactly right, again, before you get outreach. And the contact lists are what I would be working on between the ANR submission and the June 1st start date. Contact lists are, if there's any issues with the contact list, there's really no turning back. Once you've started outreach, made that first call, sent those first emails, you can't come back. You can't come back and fix anything in your contact list. So you want to make sure that those have been deduplicated correctly, that the correct providers are in there. And a couple ways to do that are to make sure that you're using the GData files that you just submitted. Part of the vendor validation report, of course, is to compare your contact list to that GData. And if there's any variation in the two lists, if there's any providers in the contact lists that are not in the G data, then the department's going to need a write-up as to why, an explanation as to why when you submit that vendor validator report. So it's really just easiest to make sure that you're using that G data submission to build your contact list. Another challenge in the contact list are FQHCs and RHCs. Of course, FQHCs are surveyed at the entity level, even though there may be multiple providers working at that FQHC. We just want the entity as a whole. So when you're looking at FQHCs, make sure that one, you're including the FQHC, but on the flip side, if there's any providers affiliated with that FQHC, they need to be also removed from the contact list. And we actually have an algorithm in-house that our programmer built here. And what she does is she looks at the FQHCs, and of course, another challenge with the FQHCs is we don't always know which survey type they belong to. So when we're trying to assign those FQHCs to a survey type, what we do is we look in the contact list for providers who are associated either by address, by group name, a few different criteria. And we say, okay, this survey type has 10 specialist providers. So that's a specialty FQHC. Or they have 15 PCP providers. So we're going to put them in PCP. Or they have both PCP and specialists. So we're going to put them in both. So, and then on the flip side, when we're bringing in the individual physicians, we look to see if there's an FQHC that already accounts for them. And if there is, then we exclude those physicians. So FQHCs are a little tricky, but definitely workable. And again, if you give yourself the time to work with these contact lists and just make sure they're done right, then a little bit of unpredictability is okay, because you can always deal with it. We always have in our process, if we're working, for example, with an external vendor validator, we always make sure that we get their sign off on the contact list before we move into outreach. We always make sure that we get sign off from our client as well. And if we're also doing vendor validator work in addition to the outreach work, then we have internally a duly signed process where two or more people will independently verify key points and key milestones to make sure that we're on track and that we're doing everything according to the methodology. So anytime you can get additional feedback or another perspective or an independent verification, it just gives you that much more reassurance that you're just doing it correctly and you're following the methodology. So it's, again, the contact list, I can't stress enough just how important they are to have accurate before you jump in, because we can't turn back the clock. If you wait until the end of outreach to look at your contact list and you find something wrong, that water falls through the whole process. One thing you can do when you're preparing your contact list that will have an impact on outreach is you do have to include providers who may have terminated. So there may be providers between January 15th, your capture date, and June 1st, your outreach start date, that have been terminated or that are ineligible for some other reason. They retired, they moved on. Those providers, we can mark them as ineligible. We do have to include them in the contact list, but in terms of the raw data and the outreach, we don't actually have to reach out to them. If we already know that they're ineligible for one of the reasons listed, then we can mark them ahead of time. For example, if you may have had a large group that you terminated that may account for 50 or more providers, any providers that you can mark ahead of time that you know of and that you know the call would be wasted on in terms of being ineligible are helpful. But of course, the large groups are where you're going to see the most impact. So just be aware when you are preparing your contact list, particularly when you're moving on into the survey phase, that providers that you know are ineligible, you don't have to make that call. And again, contact lists. I know I keep saying this, but as many eyes as you can get on these contact lists, the better. Like I said, we can't turn back the clock. So get those right before you go. Finally, for sampling on this page, sampling, we typically recommend doing a census. What we've found in particular, the rule of thumb that I use is that a provider population of 350 or fewer, it's just better to do a census on, even though your sample size may be a third of that, right? May only be 100 providers. In our experience, provider groups of that size, populations of that size, given the non-response rates, typically require outreach to the entire group anyway, or very close. And if you're doing a random sample, which we'll talk about a little later, some outreach strategies, but if you're doing a random sample, it throws a little bit of complication into the works, which we'll talk about in a minute. But in terms of sampling, we really recommend, like I said, census on counties with fewer than 350 providers. Now, if you know based on your history that you have a high response rate in certain survey types, for example, your response rate in the PCP to PCPs may be like 80%, then you can factor that in, and maybe you don't have to do that census. Although I still may recommend it, you don't necessarily have to do that random census if you have a high response rate historically. However, I know, for example, in non-physician mental health, the response rates are typically a lot lower just because of the nature of the mental health practice, and they may not have offices or office staff. They may be working individually or on their own, and you may be leaving a lot of messages and maybe not getting a lot of return on those messages. So it does vary, but like I said, my rule of thumb there is 350. If you do have to do a random sample, it's not always viable to do a census. There may be counties where you have thousands of providers. So if you have to do a random sample, there is the option, of course, in the methodology when you're preparing your oversample to just take a portion of the remaining providers who are not sampled and assign them as the oversample. I would really recommend just doing 100% of the remaining providers, just planning on them for your oversample. It's unlikely that you'll have to reach out to 1,500 providers, right? But if you only put 200 providers in your oversample and you run out of them, and then you have to go grab more, it just really gums up the process on the other side. It's just better to do 100% oversample and bring them in as needed. It's not really a whole lot in terms of data. When you are doing a random sample, one thing I would recommend is a buffer. So we typically will use a buffer here. If you can look at your historical years and historical response rates, and you know, for example, that in X county or X survey type, you have to make 5 calls to complete 1 survey, then maybe you just automatically say, hey, I'm going to reach out to 5 times the required sample size, or even better, 6 times the required sample size. It's okay to collect more than what's needed and cut off your results at the end. As long as you're making sure, of course, that whatever number you decide to reach out to, you're sticking to that 50 to 60% window when you're actually performing your outreach. So 50% in wave 1, 50% in wave 2. As long as you're sticking to that window, that can be calculated, including a buffer that you include. And again, I'll talk about it in a minute, but doing that kind of makes the management of the downstream of the 3-step outreach a lot easier. And finally, again, It's impossible to fix issues from this stage. When you move forward, once you make that first call, you can't come back. So make sure even in your sampling that you're looking at it 2-3 times, that you have multiple eyes on it, that your vendor validator has signed off on it, that someone at your plan has signed off on it. It's just things that could impact the sampling. For example, is if you didn't calculate your deduplication right. So say you had one provider, but there was a data entry error on one of their rows, and they had what looked like 2 NPIs that were really 1 NPI with just some transposed characters or something. So that would technically be a duplicate, but the data wouldn't necessarily reflect it. So we have reports that we look at very thoroughly. We run all the providers against the MPAAS registry. We check to see, you know, if the MPI is assigned to somebody else in the MPAAS registry. We look at providers who are maybe have multiple MPIs. I mean, it's not uncommon for 2 people to share the same name, but we do have a report that says, okay, there's 2 people named John Smith. They have different MPIs. It just our report flags it, and then we do a manual review, and we say, okay, you know, that's okay. One of them's a cardiologist, one of them's a family med provider. They're in different cities. They're obviously not the same person. That's okay. On the flip side, we also look at people or MPIs that are assigned to more than one individual in the contact list. So we do a lot of checking, a lot of work beforehand, again, just to make sure we have a good foundation to start from. And we have a very good working relationship with various vendor validators to where they do this type of pre-assessment for us regularly. We've started including them a few years ago, and it just really makes the process a whole lot smoother. Okay, we can move to the next slide here. In terms of survey outreach, so after you take your sample, after you build your contact list, you move into survey outreach. Again, for survey outreach, I really focus on a census method. It just makes everything easier. We used to try and do random samples. Like I said, I have a rule of thumb of 350 or fewer providers to automatically assign as a census. Historically, we've tried to manage closer to the sample size, but what we found was that, you know, we'd get to the end of our schedule, and we'd have maybe 10 providers that we needed to complete, 10 surveys that we needed to complete, and we'd make the 10 calls one day, and then we'd have to wait 2 days, right? Because when you make the call, you have to give the provider, if you're leaving messages, you give the providers 2 days to respond to those messages, and then you mark them as non-responsive and you replace them. Or they may call back and they may be ineligible. But on those 10 providers, say you reached out, 3 of them responded and completed the survey, the other 7 were ineligible or didn't call back, then you have to make another 7 calls. Then you have to make another 5 calls, another 3 calls. And those 10 providers could really take you weeks, potentially weeks to wrap up. And I just call those types stragglers. So if I do have a random sample that I have to do, I try and I will take the random sample county and I'll make that my priority for outreach. So I'll say, okay, these 10 counties are random sample counties. I'm going to send these emails first. I'm going to put these on the call logs first. And then after we've wrapped those up, or after we've made some good headway on that, we move into census while we're waiting for that 2-day lag. Then we go back, we look at it, we still have a few weeks, and we just keep going, keep hitting that random county, but making sure to wrap those up as early as possible, so that we aren't hitting the end of the wave and those stragglers aren't holding us up. One thing you can do to significantly increase proficiency during outreach is, of course, to use knowledgeable staff. We do have a survey team here at Mazars that many of them return year over year to do this work for us. We typically have about 75% of them who return and maybe a few who are new. It really gives them a good dynamic. The returning people are very experienced in the type of scenarios they may encounter. They can run role play or provide feedback during training that is invaluable to the new surveyors. So just try and bring back knowledgeable staff as you can. And make sure that you're including role playing during any training. There are a lot of scenarios. There are people who may not know about the survey or may not be aware that they have to participate or may think it's a scam or may not be familiar with your health plan because they may be outside of your service area but still required to be surveyed just because they're technically in your network. So, but they may not know who you are. So those types of things we include in our training and as prepared as you can be before you go out. Of course, there will be issues during outreach. There will be scenarios that you can't think of. We have a tool here that we built in-house for managing our outreach, and it provides live feedback on data entry errors, questions that the surveyors may have, training opportunities. So as much as you can, be prepared, but also make sure that when you are conducting outreach, you have a mechanism in place to monitor and oversee and retrain as early as possible, when you are performing outreach, of course, Sunshine mentioned the focus, the ongoing going forward focus on response rates. You know, it's very hard, especially in smaller counties, to achieve those sample sizes. I think it's any county under 14, you basically have to sample the entire thing. And if you miss one provider, if one provider's on vacation or out of town or sick or just can't respond within those 2 days, you know, that all of a sudden just makes you makes you unable to reach that sample size. So a couple of outreach strategies that may help to get as close to that, get as high of a response rate as possible, is one, extraction. You know, if you have contracted groups particularly groups with centralized scheduling available, so one person who can, for example, look up the schedule for multiple providers, then that is a perfect candidate for extraction. You can schedule a time with them to sit down and go through the providers and just in one call, knock out all their providers. Okay. And it really can help to boost those response rates to make sure that you don't have as many non-responders. Even an ineligible response is at least a response. And you're guaranteed a response through extraction. There's no scenario where you get on the phone in extraction and they say, nope, I'm not gonna respond for this provider, right? I mean, I guess it could happen, but typically, as long as the provider's in their system and active at their group, they'll respond to the questions. You may have a scenario where the provider doesn't work there anymore, or they just don't know who they are. They've never heard of that person, and that's okay. But that still equates to an ineligible provider, which is better than a non-response. The other outreach strategy we will use pretty frequently, which we have to use, unfortunately, is the three-step protocol. But when you are engaging in the three-step protocol, of course, the 3 steps are: 1, you send out an email invitation for providers to participate in the survey. 2, after a couple days, you send out a reminder to non-responders. And then step 3 is after a week, if you haven't heard back from, well, 5 business days. If you still haven't heard back from a provider, then you follow up with a phone call, and that phone call needs to be made within 10 business days of that expired email. I would say, for as much as you can, get those get emails for as many people as you can. We, in the last year, I think prior to this year, we typically had between a 5 and 10% response rate by email. Sometimes going as high as 15, but still pretty low. But this year we have experienced a significantly higher response rate by email. Typically 40% is what we're looking at this year in terms of for the number of emails that we sent out versus the number that responded. And that is huge. So meeting the provider where they prefer to be met is huge. If you can get an email, send those emails. Speaking of emails, one thing we've realized when we are sending emails is that we may have individual unique emails for each provider in, say, a particular group. Sometimes we'll have up to 20 individual emails and we'll send out one email to each provider, and then a couple of days later we'll get an email or a call from somebody at their organization that says, hey, I've received these emails from about 10 of my providers. I'm wondering if you could just send me all the ones you have for us to complete, and just send them direct to me and I will complete them all for you. And that's great. But we could have sidestepped that scenario if we had that person's email in the first place. So for large groups, maybe during intake of large groups, one thing we can do is say, hey, we have these surveys that we're required to do every year. Do you have an office manager or an admin that can respond to these, and include their email as well for purposes of these types of surveys? Would really get us around that step. And also, if we're sending out individual emails to 10 out of the group, maybe 5 of them respond, maybe 6 of them don't. Or sorry, 5 of them respond, 5 of them don't. Those are non-responses then. And furthermore, every email that you're able to get a response on, that's a call you don't have to make. Those calls are time consuming. They're hard to track. There's just a lot of variables that go into a call. So if you can head that off with an email, it's huge. It's a very big step towards, like I said, those even those non-response rates. Because typically, if they respond by email, the response is, they completed the survey or they're ineligible. I know. I feel like I'm spending a lot of time here, so I'm going to try and pick up the pace. Let's move on to the next slide. I have a couple more slides to get through when we want to save time here. Excuse me. Regarding our tools and our execution of the survey, we've used a number of tools to try and get through this survey. In the past year, we went so far as to create one ourselves. We have one in-house that we created that's based in the cloud, and that we're able to deploy the survey, track progress, track data entry errors, track training issues, track questions. And again, it just makes the whole process easier if you have the right tools. In the past, we've had to use a few different systems. For example, we'd use a survey software, but then we'd have to download the data out of that survey software and into another environment to analyze it. We'd have to then take it into another environment to process it and put it into the final templates. So as much as you can get that all in one place, and as much as you can get that process going on live data, the more beneficial it is. We do also use what's called robotic process automation. We have a team here that specializes in RPA, what it's called RPA. And what it is it uses a virtual computer, a bot essentially, to do repetitive tasks that may take a human, say for example, an hour, but maybe a machine can look at that same data and finish it in 30 seconds. And of course there are some limitations to it, but as long as the task is, like I said, repetitive and consistent, then then a bot can do it and takes out those manual processes. Anytime you introduce a manual process into your process, it just is a risk for something going wrong. And say you fix it this time, you start over again, you fix that one thing that went wrong the last time, but maybe something else pops up because you forgot another step. So as much as you can automate is huge. We have internally here a SQL programmer and DBA who manages our database and has a custom script that she runs on all the data. And that just ensures that every time it's done the same way, exactly the same way every time from start to finish. If you have the right tools, I just can't emphasize enough how much more streamlined it is, especially the larger and more data you have to work with. Okay, we can move on to the next slide. This is the last best practices slide, but not the least by any means. We'll talk about the templates for a minute. Of course, you have three groups of templates. You have the contact list templates, the raw data templates, and the survey results templates. When you're preparing those, one thing to pay attention to is that there are slight differentiations in each template. For example, in the primary care template, you may have some advanced access fields that you need to fill out. You may need to include mid-level primary care providers. So just make sure that you're paying attention to those differences. Of course, for ancillary providers, there's no urgent requirement for ancillary providers. And again, automate as much as possible. What we do is we have kind of an intermediary table, we call it, which is a combined, essentially, contact list raw data so that it has all the different survey types in one place and we can really do some heavy analysis on it. And then when it comes time to actually create the templates, we export it to a custom report. So we take it out of our SQL environment, we push it out to Excel, and it outputs into Excel in exactly the way that the DMHC wants it. All the fields for each survey type are clearly defined. We've checked all of the fields for the correct data in there. And from that point, we can just copy it and paste it right into the templates. And then we do some additional analysis. Like I said, we do oftentimes perform the vendor validator component as well. So we do take those final templates and do some independent analysis on those actual DMHC submitted templates. But this really helps us in terms of the preparation phase to make it as accurate as possible and make sure that the validation side goes as smoothly as possible. And finally, quality control. Of course, you should be conducting quality control as you go through. Do not wait till the end of the process to go back and look at and do your quality checks. Involve your vendor validator early, getting the sign off on those contact lists and the deduplication, like I mentioned before on the first slide. Make sure that your CL is built from the G data. We use a checklist here. We took the methodology and we prepared ourselves a checklist of all the steps that we have to go through. Everything that we need to verify, it's all on a checklist. We go through that checklist. We have 2 to 3 people going through that checklist, making sure that we're doing everything right. I know I'm getting some time notices, so I will with that just close out the best practices session and hand this back over to Sunshine to close us out.
Real quickly, I just want to mention some quick pointers on your CAPS. Consider contract language updates that will address participation in PAAS. This can come in the form of incentives to your providers for participating, or maybe fines and sanctions for repeated non-participation. By drafting participation expectations in your contracts, you put the onus on them to be eligible. This really feels like what the department is gearing towards, making the health plans hold the providers accountable for participating and pushing the enforcement off of the DMHC's plate and onto the plans. We have all been conducting PAAS for multiple years by now. Put that historical data to use. Identify providers who have repeatedly been non-responders and focus on pre-outreach efforts towards those providers. Identify large groups and schedule those for extraction. Even groups with as few as 3 to 5 providers could benefit from extraction if there are groups that have historically been non-responders. So I know we went through a lot of information rather quickly, but I do want to open it up to questions. I do want to hear what our plans and what our guests have to say. So please, if you have a question, you can put it in that QA box. You can raise your hand and our admin will allow you to come off mute so we can have a robust discussion. So please, any questions out there? Have we just dazzled you with all of the information? There's just nothing out there. We've answered every question. Nothing's keeping you up at night.
I will say, if you do have a question, please raise your hand, and then our administrator can take you off of mute here to ask that.
Well, okay. I want to thank everyone. If we don't have any questions, I do want to give Daniel an opportunity to talk a little bit about some things that we might have rushed through to give everyone questions. Oh, wait, we might be getting a couple coming in. Oh, just thank yous. Well, you're welcome. Thank you for all attending. And as I mentioned, we will have this recording sent out to you all after it gets kind of edited and packaged up, and we will also have the slide deck available for everyone who attended. Oh, we do have a question. Hey.
If you were the one that just raised your hand, please raise it again so I can unmute you.
It was a phantom question. Ah, raised by accident. Okay. Daniel, did you have any other kind of things that we skipped over to get to the end to give time for questions?
No, I think I got through everything I had on my bullet points. Thank you though, and thank you everyone.
I know we did stress email outreach. I can't stress enough how much that has really improved our outreach this year. Getting that up to 40% response rate is critical. I think that's really going to help plans get more response rates because providers are more likely to click on a link than they are to respond to a voicemail. All right, well, thank you everyone for attending. I really appreciate everyone's time. And if you come back later and think of a question, don't hesitate to send it out to either Daniel or I, or really anyone at the Mazars team if you have contact with someone else. And it don't have to just keep it related to PAAS. We have a robust team here that can really answer any of your healthcare questions. So don't hesitate to ask if you have any questions.